Thanks, Marish, and it's great to see these conferences taking place again because it shows you how much more richer they are in terms of engagement and networking than Teams or Zoom, which can never replace the simple human act of coming together and listening to each other and swapping ideas, and what we call networking, which is, I suppose, in another way of saying that we're all greater than the sum total of our parts when we're together. So I just want to go through, Marish referenced the pandemic, and I want to use that as a springboard to this 10 minutes. I'll try to keep to that, Marish. You can knock me off the stage if I go over. I see it there, thank you. So look, big numbers there. We had lots of cases, healthcare workers, nearly 100,000, unfortunately, over 8,000 deaths. Many different phases of that pandemic. The early stage saw the pandemic rage through nursing homes, and later stages they were much more heavily protected because we learnt as we went along. And there's a theme there that we began in ignorance. We began with no knowledge. We began with a virus we knew little about, but we learned and adapted quickly. And the whole story, when eventually the world settles down to write this story, is one of human ingenuity catching up with an existential threat, namely a virus that threatened to destabilise all our healthcare systems and cause a huge amount of death and illness, which it did anyhow. But the ingenuity of research companies, of governments, of people coming together, of advocacies, that wonderful coalition that came together in every country and between countries has got us a situation where we can meet here today. So today is the end point of this stage of the pandemic, which marks a big success compared to the last time I was in this hotel when we were, I think, was occupied totally by 3 or 4 HSE employees as one of 5 hotels open in Dublin, catering for those of us who are working centrally. Ireland's response to the pandemic, big jump in hospital capacity. We were on the edge of limits, 95% occupancy, 100% occupancy. I knew it wasn't enough, and like many other countries, we had shaved it too tight. We went, that first case that Maurice mentioned, we waited 5 days while that teenager waited in the hospital in Dublin for the test to come back. And then we peaked at 180,000 tests per week from our own homegrown test and trace system. Vaccination programme, I think 12 million vaccines given to date, a coverage of population, the adult population of 96%. ICU beds, increase of capacity from 255 to one stage 350 when we were in big trouble. Recruitment and redeployment of healthcare staff at pace, widespread adoption of telemedicine, huge sudden upscaling of community avoidance or hospital avoidance ways of delivering care, and so on. As Van Morrison might say, wouldn't it be great if it was like this all the time? But that was what pandemics did, and that's what fear does. It prompted us into action. And that vaccine programme, really quite astonishing levels of uptake, haven't been matched as we've gone along, because we know, as again, learning from human behaviour, the biggest single driver to people uptaking the vaccine was fear. And we don't see, thankfully, because normality has resumed, we don't see the same levels of fear. And one of the trade-offs for that is people just aren't as willing to take the vaccine as they would have been some time ago. Public health restrictions. That left-hand side is Grafton Street or just off. I think it's Wicklow or Suffolk Street or one of those streets. Pre-pandemic, and the right-hand side was one of the me returning from one of those daily press conferences in the Department of Health in phase 1, and that's Stephen's Green at 3 o'clock on a Friday afternoon. And that's, people have forgotten, and there's a kind of collective amnesia. None of us want to go back there and think of absence of memories, let alone unhappy memories, with what were really very, very destructive national lockdowns, because there was, in the absence of any other specific treatment, that's all we could do. And you remember this: stay at home, travel within 2 kilometres, no household visits, everything shut, remote working, closure of all non-essential retail and service. That's only a short while ago, and it already seems like a very far distant memory, as if you could nearly convince yourself it never happened. And what were the consequences? Well, it was a sudden, people often talk about economic shock, which it was, but there was a sudden shock to healthcare as people just stopped coming. And I'm not talking about people who had elective and non-urgent conditions, even time-critical conditions such as myocardial infarction, such as stroke. There was a drop in attendance. The right-hand graph shows a drop in ED attendances and ED admissions for those first few months in spring of 2020. But we saw, as we delved deeper into the data, was proxies for cancer activity, investigations, endoscopy, biopsies, all dropping. And as a result, a fall in about a 15% drop in cancer diagnosis during 2020. And those cancers don't go away. They come back later and more upgraded. And like other countries, we are now paying the hangover price of healthcare suspended and delayed during the pandemic, and during the lockdowns and having to deal with the aftermath. Reflections, health systems, healthcare workers were not prepared right across Europe and America. They simply weren't prepared for something like this. They were exposed as under-resourced and fragmented. Hospitals were everywhere, not just here, but in Milan, which in northern Italy has a very well-developed healthcare system, collapsed under the strain of unmitigated COVID transmission. Public health systems had to switch completely to health protection. Health systems scrambled in a very unseemly and uncivilized way between nations, scrambling to fight for PPE, for testing. There wasn't always the level of cooperation you'd like to think. At one stage, we were transporting, as people might recall, desperately transporting by Aer Lingus planes PPE from China. And if we had an RAF, which we didn't, the RAF would have accompanied the planes to make sure they safely landed in Dublin. Such was the level of fear over what might happen when you secured PPE. And the impact on healthcare workers is substantial. The Nuffield Trust, some of you might be familiar in London, did a kind of looked at all countries and their response. And what they found was that we need to double up and reform. That apart from all the public health messaging here, is our journey towards integrated care, towards multiplying exponentially the kind of places you can access healthcare by expanding the kind of healthcare professionals who can deliver complete healthcare, not just consultant-delivered pathways, but physiotherapists, occupational therapists, advanced nurse practitioners. We need to double up on this. We need to create a healthcare system that can't be punched below the belly and collapse simply because everything is funneled through a small number of pathways. We need to increase the number of pathways to a huge amount so that people can access healthcare. And we've begun that through the Enhanced Community Care Scheme, now looking at 96 networks across the country, 30 hubs for older people and for chronic disease, and they're already well under staffing and funding of 240 million. Sounds like a lot of money, but it's only a fraction of what the HSE actually spends on healthcare. A case for reform, apart from the pandemic, our population is getting bigger. It's more diverse. Lovely slide there I saw on older people. Yes, there's lots more of them, and that's good, but they're not always surviving in a healthy way. And big thing, people are expecting more. And they're expecting, as soon as we bring improvements to people through primary PCI, through thrombectomy, that becomes a new standard against which people measure their own experience. And then left-hand side, my hospital, original hospital I worked in Cork. That's, if you go there, like the Book of Kells, I turn the page every day of the admissions there from 1857. You have the name, you have the profession, you have the disease, and you have the outcome. And there's only 2 outcomes. And you can work that one out. And it's very simple. That was healthcare then. Transactional, you come in, you get treated, one of 2 things happens, and that's it. What is healthcare now? The right-hand side shows the expansion of chronic disease, people surviving with chronic disease, and yet we have a healthcare system that we expect, which is transactional and episodic, that we expect to deal with people with more chronic, long-standing chronic disease that really isn't well matched to emergency departments through which you get multiple investigations, often provided by a junior doctor in the first place without some specialist hubs. Sláinte Care is the direction of travel. It's not a perfect document, but as Mike Ryan said during the pandemic, you can't wait around for a perfect document. But everybody kind of knows what it means, even though there's gaps in it. There's not much for mental health, for example. There's very specific targets for diagnostics, but not telling you how to do it. But everybody kind of gets the message of what Sláinte Care means, which is, again, spreading healthcare out from hospitals into the community and providing healthcare at what's called the lowest level of complexity. Public health reform is a big part of that, and that's one of the big pieces of work carried out in my office, led by Deirdre McMarriage here in the audience, disease prevention, and it goes way beyond the health protection that we're so accustomed to what they do during the pandemic, but improving health. And that's part of geographical reform too, with the regionalisation, RHAs, which we're working on at the moment. Just want to touch on genetics and genomics, which has been much the theme of the great previous speakers. We know what it is. Again, a lovely slide in the last presentation showing the potential. Earlier diagnosis, tailored treatment. I'm convinced now when I talk to my colleagues in oncology that in 10 years' time we'll be looking back at patients getting chemotherapy regimes, which in some cases are decades old, and saying, isn't it incredible that we give everybody with ovarian cancer and endometrial cancer the same chemotherapy regime and didn't select out those who are more likely to benefit and those who are more likely to get side effects and so on. So we're looking at tailored treatment, not just in oncology, in cardiology. We now know through engagements with Joe Galvin and his colleagues that many sudden adult deaths, such as an underlying genetic issue that can be identified in families. Owen Smith has pushed us through this with extraordinary patience. I know he's in the audience. I can't think of a Beatles song to correspond to your enthusiasm for pushing us this, Owen, but I will think of one. Is that we've all this has been harnessed together for us to push forward a national genetics and genomics strategy, which will be launched this month, hopefully by the Minister in mid-December. And we really want to bring us from a situation where Owen and other people have identified, frankly, not a very spotty and inconsistent service in terms of quality and timeliness, and one where that then becomes a self-fulfilling failure, that people don't want to work in it, and we can't attract the brightest and the best, and we export our researchers and doctors abroad to one where we want to be really the best in Europe or best in the world, as the Sec-Gen said to us last week. And I believe this strategy, while it's high level, it sets us on a first step towards that. And in it, we're looking at issues of biobanks, we're looking at a directory for testing, we're looking at our lab infrastructure, and of course we're looking at the manpower and resources. How can we get the best people into this? Into genetics and genomics and contribute to our situation, our service in Ireland. These are examples of some of the rollout of drugs testing in oncology. It's expanding, as again previous speakers have said, in a way that we never could have imagined in recent, only a few years ago. And the potential scope of application of genetics and genomics is enormous. It does not belong, as Owen said, ghettoized in genetics medicine. It belongs to all specialties, and it should become part of the training and language of patients and of advocates, and of course of doctors and nurses everywhere. So just going, I know I'm gone over my time, but we will be launching that in mid-December. It's a big piece of work. It's taken place in rapid time. Huge contribution due to, or acknowledgement due to Deirdre McNamara and her team for driving this, for Owen for giving us a kick up the you-know-what, for Merish and the Department of Health for supporting us, because the closer these things get to the finishing line, the more difficult it gets. I'm very aware that strategy is 5%, implementation 95%. But between the people we have on board and the advocates we worked with in devising this strategy, the 11 advocates who sat through some very techy discussions, and very difficult for them to contribute, but we opened every single engagement we had with patient stories, which didn't always reflect the best experience. And it's something I think we can all feel very positive about. And the recommendations they'll be published in mid-December. They'll look, as I said, establishing a national genetics and genomics office, which will drive those other recommendations, which I think will become a power with the National Cancer Control Office and NWHIP. In other words, one of those big programs of care that the HSE is driving in collaboration with the department in a multi-annual funding basis. So that's it. Thank you very much for listening. Just special acknowledgement also to Anne Lawler, who I go to these conferences to escape from her. She manages to track me everywhere. If anyone wants to know what a patient advocate should do, she should be lecturing in this, which is never give up and persist. So thank you.